If you have been diagnosed with a medical condition, do you know how much that diagnosis is worth in the insurance market? Today we are diving in the world of medical risk adjustment and value-based care and revealing some surprising truths about how the system really works, not to make you healthier, but to make more profits. Profits of more than $50 billion. Welcome to PCP Lens, where we journey through metrics, money, and madness and unpack some complex healthcare topics. My name is Sudeep Bansal. I'm a primary care physician in Connecticut and I run my own medical practice. In this video, we'll explore how healthcare budgets are calculated, the intricate world of medical risk adjustment, why your medical records might include more diagnoses than you expect, and how the system is exploited for profits while negatively impacting both doctors and patients. Let's start by examining how healthcare budgets work in value-based care. The first and most obvious question is, why do we need a budget? We need a budget because there's limited money and we need the ability to predict the cost of care. So for Medicare, this means they need to allocate funding for the following year. Private insurances need a mechanism to predict the cost of care for the following year so that they can maintain their profit margin and hopefully not sustain a loss. This, by the way, also helps private insurances decide the monthly premium they're going to charge people next year for their health insurance. The budget is calculated predominantly using two factors. The first is demographic factors, which include age, gender, zip code, Medicaid status, if a person is living in a long-term institution, or their disability status, such as the inability to move one side of the body after a stroke. The second one is, how sick is the patient? That is, your pre-existing conditions. This is based on diagnosis codes, also called ICD-10 codes, which are submitted by doctors and hospitals when billing for services. If your doctor diagnoses you with both CHF and COPD during an office visit, the insurance will allot a higher budget for the next year compared to someone who was diagnosed with CHF only. But the ICD-10 diagnosis code set contains approximately 72,000 diagnosis codes. Conducting an actuarial analysis for each and every individual code can get very complicated. Enter Hierarchical Coding Conditions. HCCs categorize diagnoses into related groups based on clinical complexity and expected future healthcare costs. This table shows an example of several diagnoses with their respective HCC categories and the risk adjustment factor score, also called the RAF score, that is assigned to them to predict the cost. Besides HCC, there are several other risk adjustment factor models in use in different health insurance plans and in different states. Insurance companies may use different models depending on the specific population and internal actuarial calculations. For our purposes, we will continue with HCC model to look at how it is used to calculate the future cost of care. The actual calculations are very complicated. The calculations that I'm about to present are extremely simplified and should be considered similar to the back of a napkin calculation, but it still serves the purpose to give you an idea on how this can be gamed for profits. Okay, the expected healthcare cost is calculated by multiplying the risk adjustment factor score, or the RAF score, by the average expected expenditure in the measurement year. For example, diabetes has a RAF score of 0.166. And the average healthcare cost per person in 2022 was approximately $13,493. Now we can use the above equation to calculate the 2023 expected cost per person, which turns out to be approximately $2,239. Now this number is very low as we did not add the expected cost due to demographic factors. Now that we understand the basics, let's walk through how the game is played. Here we have three hypothetical patients, Joe, Sally, and James, with multiple medical conditions. Using the formula that we just discussed, we can calculate the expected costs. Joe, who does not have any medical conditions, is not expected to cost any money. Sally, who has diabetes, is expected to cost just over $2,000. And James, who has diabetes and heart failure, is expected to cost approximately $5,500. As you can see from the table above, capturing all the medical conditions is crucial, as it makes a big difference in the budget. Even if the organization is able to reduce the total cost of care, it will not achieve any shared savings if the budget is set too low. In a value-based contract, there are only two ways to reduce the total cost of care. The first is to actually decrease the total cost of care. This can be done by decreasing utilization, that is, people use fewer medical services or services are being denied by insurance companies to lower the cost. Next is to lower the cost of services. For example, discharging patients earlier from the hospital to a skilled nursing facility, which is cheaper than the hospital. And by decreasing prices paid for healthcare services, that is, reducing reimbursement to doctors and hospitals. The second method is to capture all medical diagnoses to increase the allotted budget for the following year. Since it is very hard to reduce the total cost of care, most organizations predominantly focus on appropriate risk adjustment. Essentially, this involves finding and documenting any diagnoses that will increase the risk score and therefore the budget. Since the diagnoses codes form the basis of the budget, the focus of most organizations in a value-based care contract is making sure that these codes are accurate. However, there's a fine line between accurate coding and upcoding to make people look sicker. The art of making people look sicker falls in two categories: coding or billing for non-existent diagnoses, and exploiting disease thresholds to inflate the diagnosis. Let's start by looking at coding and billing for non-existent diagnoses. Hypertension and atrial fibrillation are two separate HCC categories, but only atrial fibrillation increases the risk score. These two diagnoses can be independent of each other, but clinically you can make an argument that long-standing hypertension may lead to atrial fibrillation. Providers in a value-based care contract are incentivized to increase the risk score by making a judgment call and adding hypertensive heart disease as a third diagnosis, increasing the risk score by 0.24. This almost doubles the allotted budget. Another example, and CMS recently closed this loophole, is in people diagnosed with depression. Under the old V24 HCC model, depression NOS that is not otherwise specified did not have an HCC value, but major depression has an HCC value of 0.405. Adding major depression and hypertensive heart disease to a patient dramatically increases the budget from approximately $3,600 to over $12,000. Now let's take a look at how disease thresholds exploited to inflate diagnoses. As people age, the lab values change, sometimes falling below the cutoff thresholds for disease classification, even when the disease is clinically insignificant. This issue is exploited under value-based care contract to label patients with diseases that are either non-existent or unlikely to cause future problems. Let's take a look at a couple of examples. Peripheral artery disease occurs due to decreased blood supply in the legs due to blocked arteries similar to the heart. Clinically, peripheral artery disease typically manifests as leg pain during walking. It is diagnosed using what's called an ankle brachial index test, which has a cutoff of 0.8. However, if a person has an ABI of 0.79 but experiences no leg pain while walking or cannot walk due to arthritis, which limits the ability to elicit symptoms, can we truly consider that this person has clinically significant peripheral artery disease? Many health insurances send providers to patients' homes to perform an ankle brachial index and exploit the ABI threshold to document that you have peripheral artery disease and increase the allotted budget. Glomerular filtration rate, or GFR, is a measure of kidney function. Chronic kidney disease stage 3 is diagnosed when the GFR is below 60. Now, GFR is calculated using a blood test called creatinine, which is not a very accurate test, especially when people start getting older. So if an 80-year-old individual has a GFR of 59, do they truly have significant chronic kidney disease stage 3? Now that we understand some of the common techniques for risk adjustment, let's make a fictional patient called James look sicker using these techniques. James is 80 years old and has hypertension, depression, diabetes, and mild heart failure. The insurance company calls James and tells him that his insurance plan covers one provider visit at home, and they're going to send a provider who's employed by the insurance to his house to make sure he's doing well. The provider visits James and changes his diagnoses of depression to major depression. He changes diagnoses of heart failure to systolic heart failure based on an old echocardiogram report, and then also adds diagnoses of chronic kidney disease, as James had a GFR of 55 during his last visit with his regular doctor when he was complaining of dehydration. Now, this provider also performs an ankle brachial index, or ABI, on James and tells him that he has peripheral artery disease, as his ABI was 0.79 in his left leg. Mind you, James has arthritis in his knees and generally cannot walk more than a mile, so he will not be able to walk long enough to elicit pain from decreased blood supply to his legs. At the end of his home visit, James' total RAF score changes from approximately 0.4 to 2, and this increases the amount of money the insurance company can collect from CMS, which runs Medicare, from approximately $5,500 to over $20,000. Now, as noted before, a couple of these loopholes were closed in 2024, and the insurance companies are fighting CMS so that they can continue to drain the Medicare fund. So how does this impact you, the patient? Value-based care contracts have mainly focused on people with Medicare and Medicare Advantage plans. That is, mostly people who have retired. However, more and more value-based care contracts are being used in commercial populations, which will impact disability and life insurance policies. One unintended consequence of risk adjustment and appropriate coding is that people will be diagnosed with more medical problems. I'm not an actuary, But my understanding is that adding more diagnoses for risk adjustment will increase the premiums for disability and life insurance policies. Therefore, the financialization of risk adjustment creates a monetary windfall not only for health plans, but also for any company involved in disability and life insurance. Now, let's talk about the role of risk factor inflation and the supposed money that is saved in value-based care contract. Over the last several years, Medicare Advantage plans have used the uncertainty of making diagnoses to game risk adjustment. All Medicare Advantage plans have hired an army of providers who are heavily incentivized to find medical diagnoses to drive up risk adjustment. Most of these providers are nurse practitioners, and since they can practice independently in most states, they are sent to patient homes to evaluate and document all the medical conditions. They are also trained to perform an ankle brachial index and diagnose peripheral artery disease. An expose in the Wall Street Journal recently showed that how this risk factor inflation has led to private insurance plans to pocket more than $50 billion from Medicare for diseases that did not require any treatment. While I cannot find good data on the gamification of risk adjustment in provider-led ACOs, after talking to several providers nationwide, I know that this is happening. Providers are being heavily incentivized and penalized in all ACOs to document all medical conditions properly, much to the chagrin of frontline doctors taking care of patients. When accounting for risk factor inflation, most of the savings touted by these value-based programs, they turn out to be an illusion. The question then becomes, why are we subjecting primary care physicians to this clerical exercise? The reason for this is because it allows health plans to blame providers for rising healthcare costs while they pocket all the profits. So how does this impact your frontline PCP who's trying to take care of patients daily? There's more clerical work and decreased time for patient care. Since PCPs are responsible for the whole health of the individual, insurance companies have determined that they are responsible for the appropriate risk-adjusted coding, even if several conditions are being managed by specialists. For example, if a cardiologist is managing heart failure, it is the responsibility for the primary care physician to ensure that the proper risk-adjusted heart failure diagnosis code is billed by the primary care physician. This risk-adjusted coding decreases the time it takes to take care of patients, as providers now have to spend much more time to complete medical documentation. Several insurance companies, in partnership with risk adjustment companies, force PCPs to document these diagnoses in a different computer system that is controlled by the insurance company. This again reduces the total time available to take care of patients. Next is deteriorating relations between patients and the PCP. When insurers send providers to patients' homes for risk adjustment visits, they often find diagnoses that are not clinically relevant. Patients are then asked to talk to their PCP to address their medical issues. As you can imagine, patients get very upset as they feel that the PCP missed their diagnoses. This leads to patients to get angry with their PCP, sometimes resulting in permanent loss of trust. Then there's the financial impact on private practices. As healthcare gets more expensive year over year, insurance companies are decreasing payments to providers, including PCPs. Most providers have taken huge pay cuts in the last 10 years, especially when accounting for inflation. This impacts private practices, as the cost of running the practices skyrocketed while reimbursements have declined. Under value-based care contracts, PCPs are forced to take financial risks for the total cost of care of their patient panel. If the cost of care exceeds the budget, then PCPs must pay the insurance company back. Since small primary care practices cannot control the socioeconomic and environmental health determinants and don't have the money to pay back to the insurance companies, they're forced to join an ACO if they have access to one, to retain their independence, or merge with large practices or to sell out. And lastly, the PCPs are being forced to walk the regulatory tightrope. In the last several years, CMS and other regulatory agencies have been cracking down on risk adjustment. Since Medicare Advantage companies have been at the forefront of gaming risk adjustment, the focus of regulatory agencies is on these insurance plans. Insurance companies set incentives and aggressively penalize providers for ensuring patients are risk adjusted properly. However, this puts providers in a pickle. Since providers are responsible for ensuring accurate diagnoses, the insurers wash their hands off during an audit. The choices providers then face include not listen to insurance companies and go bankrupt, or code aggressively for risk adjustment and then risk being subjected to regulatory oversight with the possibility of being prosecuted for fraud. Essentially, value-based care and risk adjustment has financialized the healthcare system and offloaded the regulatory risk to frontline doctors. Now you can see why it is becoming so hard to find a primary care physician. You can find a written version with references to the material that I discussed in this video on PCPlens.com. You can also find an audio podcast version of this video on PCPlens.com. If you're watching on YouTube, please like and subscribe. This helps me find a wider audience and spread the message. If you like this video, please sign up on PCPlens.com so you don't miss the next episode on bundle payment when it's published. Thank you for watching this video. Goodbye.